Today we have a very, very special speaker who I have heard many times, who I know very well, and I'm sure you're going to be pleased about his presentation, even though his presentation might have to be a chalk talk, since we're still trying to figure out how to get the system working. But we will. As you know, over the years we have developed this tradition that we say a few things about historical events that have happened on this day that may or may not relate, depending on what I can find, to the topic that we're describing, because we want to ensure and remind the audience that whatever we understand today about any given condition, whatever we do, is based on the hard work and sacrifice of many, many others who came decades, sometimes centuries before us, and we sometimes forget about this link. So the speaker today is going to talk about acute lung injury, and I found a couple of facts that are kind of interesting. One of the most common causes of the adult or acute respiratory distress syndrome is bacterial infection, communicable infections. That's why the students sometimes wonder, why are you walking from one ICU bed to another with a mask and respiratory isolation and so forth? And because of recognition that these conditions can cause respiratory disease and other infections. Well, on this day was the birth back in 1856 of Charles V. Chapin, not Chaplin, Chapin. And Charles was an American physician and epidemiologist who went around and did a bunch of field studies that actually described very carefully how infectious disease could go through simple personal contact. And so in 1888, he established the first municipal bacterial laboratory in Providence, Rhode Island. And in recognition of personal communication of diseases, he established in 1910 the Providence City Hospital, where if you were a carrier of an infectious disease, you will be isolated and you will be treated by several nurses and so forth. He wrote a treatise called Sources and Modes of Infection in 1910 that was used to develop this whole agenda throughout the country. Now, one of the other things that we've learned about acute lung injury since then is that transfusions can also give you acute lung injury, particularly massive transfusions. Have you ever thought about who gave the first blood transfusion? Whoever came up with this thing. Well, it turns out Richard Lauer died on this day back in 1691, and he was the first to transfer blood from one dog to another in 1665. And in 1666, at the Royal Society, he was able to convince a gentleman called Arthur Koga. I'm not sure I would want my name listed as such, but he was an eccentric scholar, and he agreed to be transfused with sheep blood. I'm sure that went very well. That was the first transfusion in a human being in United Kingdom. The first one ever was actually in Paris, not around that time. So, and then more recently, I just saw that there's a fairly new publication that actually says that if you have acute lung injury, if you're a woman with trauma, you probably are more likely to develop acute lung injury. I don't want to steal the thunder of the speaker. I don't know what he's speaking about. But this issue about sex determination and genetics and acute lung injury is becoming interesting. Did you know that on this day was the death back in 1946 of Clarence McClung? And Clarence McClung was an American geneticist who discovered the role of chromosomes in sex determination in grasshopper. I was sure the grasshopper has sex differences, but I didn't get that far. But he actually reported how sperm existed in two different forms in each different chromosome configuration. And he was the first to report in 1901 and deduced that chromosomes determined the sex of the offspring. And this idea and many others were some of the ideas that really pushed this concept of genetics and the Human Genome Project and so forth, among many others. So we're going to learn today about new things about acute lung injury if I ever get the speaker to get his conference ready. But we're doing well, it sounds like. Marc is a seasoned guy who's not affected by anything. So in a few minutes, we'll have Dr. Rodney Foltz introduce the speaker of today. Relate to each other. Talking those for seconds. I want to remind everybody that at 9 o'clock, Barb, at 9 o'clock, there will be a meeting where?
Cardinal Conference Room.
In the Cardinal Conference Room, which is just next door. And we're going to talk about research in education. So anybody who's interested in engaging in research and education, we're going to start to develop a group here that is interested in that area. So everybody's invited. Is there anything else I should mention about that, Mark, other than that?
Yeah.
Okay. True. You're right. Oh, it's his computer. Yeah. Yes, it's computer. Email. Oh. Email. Here it is. Special thanks to Dr. Dryden, who helped us email the slides from all across the continent today. And now I leave you with Dr. Rodney Foltz, who's going to introduce our speaker.
Okay, thank you, Jesse. Good morning to everyone. Given the importance of critical care medicine, it's a real pleasure for us to be able to bring in one of the more well-known speakers and academicians in this area, Dr. Marc Moss, who is the Roger S. Mitchell Professor of Medicine at the Division of Pulmonary Sciences and Critical Care Medicine at the University of Colorado. Dr. Moss grew up in Philadelphia. He finished his medical school training, University of Pennsylvania, stayed on there to do his internal medicine residency before going to the University of Colorado to do his pulmonary and critical care fellowship. And that's where he nurtured his interest in critical care medicine. He was first recruited to a faculty position at Emory University, where he stayed for about 11 years. While at Emory, he was the medical director of the MICU and CCU at Grady Memorial Hospital. He was also the director of the MICU at Crawford Long Hospital. And in about 2006, he was recruited back to the University of Colorado as head of their critical care section. Marc has been enormously successful in academics and research over his faculty tenure. He's involved with 6 active NIH-funded grants, 2 of which he's the PI on, and I'll just mention the title of them to give you a flavor for some of his interests. He's the PI on the ARDS, Acute Lung Injury Clinical Network site at the University of Colorado. He also has a NIH-funded research in the diagnosis and treatment of critical illness, polyneuropathy. If you have an interest, he is going to give a noon talk today on a very interesting topic to us, which is entitled Uncovering the Epidemic of Psychological Distress in Critical Care Nurses. So please come by at noon up in the Pulmonary Conference Room if you're interested in that potential topic. Marc is an avid teacher. He's won the Golden Apple Award a number of times. He is the person to go to if you're interested in finding out what's going on in the American Thoracic Society meetings. He's involved every year with numerous different assemblies, committees, different programs, task forces, etc. Very involved at the NIH on study sections as well, revolving around critical care issues, intensivist issues. He has over 80 peer-reviewed publications in this field, over 50 reviews, editorials, book chapters on a variety of different topics that are very important in the intensive care unit. So please join me in welcoming Dr. Marc Moss to the University of Louisville, where he'll talk on, is there anything new you need to know in adult respiratory distress syndrome?
Sorry about the delay there with my slides. It's always my biggest fear. It's never happened before, but I can say that it's happened once. So, but I think we have it all worked out. And I just want to really thank Rod, Jesse, the rest of the Department of Medicine, and the Pulmonary Critical Care Division for inviting me. It's been a great stay so far, and I really look forward to today. So I have no disclosures. My research is funded by 3 different branches of the NIH. So I thought I'd start with this. I've actually never been to Louisville before, and I thought, wow, this is a great time to come to Louisville. Number one, as everyone in this room knows, Louisville won and beat Florida in the Sugar Bowl. I first had a great year, but it's really all been in this month. And I actually watched the game, and I think Teddy Bridgewater is the real deal. I think he really looks like a good quarterback. And then I noticed that your basketball team, who's long record of having a great college basketball program here, going back to Denny Crum, etc. But they're ranked number 1 in college basketball, and from what I understand, it's only the 2nd time in school history. So it sort of just made me think a little bit about my visit, and I didn't see Rick Pitino on my itinerary here. So I just wasn't sure if I said something wrong or whatever, and I noticed that there's an important game on Saturday against Syracuse, and I wasn't sure what my ticket was for that, but maybe if I give a good talk, that's one of the perks of the whole thing. So the outline of the talk, we're going to talk a little bit about the differential diagnosis of ARDS, a little bit about the epidemiology, conventional ventilation for patients with ARDS, an overview of what we would call advanced ventilatory strategies, talk about other therapies you should use for patients with ARDS, and then talk a little bit about some emerging themes and long-term outcomes of these patients. I was told to start with a case. This is a made-up case, so this isn't real, but it raises a few important points. So the case is a 54-year-old gentleman who presents with a 4 to 7 day history of progressive dyspnea and a dry cough. Developed some chest pain a few hours ago. Really otherwise healthy except for a high cholesterol level, and he takes a statin for that. He has subjective mild fevers and chills, and in the emergency department, he's a little tachypnic, a little tachycardic, afebrile. He's hypoxic with the room air saturation of 82%. He's given supplemental oxygen. His white count's a little high, and his chest x-ray is on the next slide. So as you can see on this chest x-ray, he has diffuse bilateral alveolar infiltrates. So the question is, what could this be? What's the differential diagnosis of a gentleman who presents with a few days history of cough, shortness of breath, subjective fevers, with a chest x-ray that looks like this? Now, this is a talk on ARDS, or the acute respiratory distress syndrome, but not all diffuse alveolar infiltrates are ARDS. So I think the first important thing to think about is, what else could this be? And I think it's clearly important because a lot of the disorders listed on this slide are treated in a different way. So the first important thing is this gentleman has a high cholesterol level, he's 54, maybe he has heart disease. So the one possibility is, could this be cardiogenic pulmonary edema? The situation was a little bit different. The person had risk factors for being HIV positive. This could be pneumocystis pneumonia or another diffuse form of pneumonia. If his symptoms were a little bit more chronic, if he presented with maybe a few month history of shortness of breath, you'd have to think about some other diseases such as bronchoalveolar cell carcinoma, of course cancer, you treat it in a very different way, or a rare disease called pulmonary alveolar proteinosis. The other thing that's important with the strong interstitial lung disease group here is that there are interstitial lung diseases that can present and be very similar to ARDS, and these would be called interstitial lung disease or related causes. There's a whole list here from acute interstitial pneumonitis, acute eosinophilic pneumonia, acute bronchiolitis obliterans with organized pneumonia that's now called cryptogenic organized pneumonia. This could all be blood in the alveoli or diffuse alveolar hemorrhage due to a vasculitis, Wegener's, good pastures, or if the person was a farmer, maybe this was an acute hypersensitivity pneumonitis. Now, I'm not saying that it is any of these, but I think as a good clinician, a good emergency medicine physician, a good internal medicine physician, a good pulmonologist, you have to take a step back, and it's just saying this is ARDS. You have to kind of exclude some of these other things The thing that's important about these interstitial lung diseases is a lot of them, such as the bronchiolitis obliterans organized pneumonia or cryptogenic organized pneumonia, is very steroid responsive. And sometimes when people will say, oh, I think steroids work for ARDS, sometimes it's because they're treating the wrong disease. So this is a sort of the differential diagnosis of what to think about when someone presents like this 54-year-old gentleman. So how was ARDS defined? Well, up until about a year ago, it was defined based on the American European Consensus Conference definition that had been in existence since 1994. And ARDS was bilateral infiltrates on a chest x-ray, a P to F ratio less than 200. And what that means is that if your PaO2 was 90 and your FiO2 was 0.5, that would be a P to F ratio of 180 and would qualify. So this isn't really extreme hypoxemia. And you had to exclude cardiogenic forms of pulmonary edema, either with a wedge pressure, with a pulmonary catheter of less than 18, or no clinical evidence of left atrial hypertension. There was also a more mild form of ARDS called acute lung injury that had all the same criteria, except the oxygenation criteria was not quite as severe. So about a year ago, there was a new consensus conference definition, and when the title of this talk is What's New About ARDS, this is one of the things that's new. There's a new definition, there are new diagnostic criteria, and it's called the Berlin definition, and it's basically the same with some important differences. The timing has to be within 1 week of a known clinical insult or new worsening respiratory symptoms. Bilateral opacities are the same. The origin of the edema is respiratory failure not explained by cardiac failure or fluid overload. And they, instead of having the ARDS and acute lung injury criteria, they now have 3 different criteria based on the oxygenation, amounts of PEEP, and we'll talk about mechanical ventilation in a second. So when you talk about ARDS in the year 2013, this is now the new definition of ARDS. To go over what are the new differences, so number one, you don't need to be intubated. So in that mild group for the Berlin definition, you can not be intubated for that. They got rid of this term acute lung injury because it was just confusing. People never knew what that meant. Acute lung injury, is that everybody, including the ARDS? Is it just the ones with the P to F ratio between 200 and 300? So they just got rid of that term completely. I still think it's okay to use the term acute lung injury when you're talking about animal models and more translational research, but in a clinical setting in an ICU, you should just use the term ARDS now. They added a 1-week time frame that gets back to that differential diagnosis in the sense that somebody who would present with bronchoalveolar cell carcinoma who had these symptoms for more than a week clearly would not qualify anymore. There was a minimal amount of PEEP required. We'll get back to that. And this Berlin definition, as we'll show on the next slide, had a better predictive validity for mortality. There are now 3 categories: mild, moderate, severe, based on oxygenation. The chest X-ray criteria was better defined, and they just got rid of the pulmonary capillary wedge pressure, the need for a pulmonary catheter, because it's not something we do routinely anymore in the intensive care unit. The one thing that was really neat about this definition is instead of people sitting around a room saying, gee, what do you think and what do you think, they actually came up with criteria and then applied that criteria to pre-existing databases to see if there was a good face validity to the new definition. And they used over 3,000 patients who met the old AEC criteria for ARDS and had sufficient information to apply the Berlin definition. What I want you to look at down here is if you look at mortality, if you looked at the ALI non-ARDS group, so that less severe group, they had a mortality of 26%. And if you looked at all people with ARDS based on this definition, it was 37%. What the Berlin definition does, not that it could be true and unrelated, but in the mild disease group, the mortality was 27%, moderate 32%, and severe 45%. So at least these criteria based on oxygenation help you risk stratify patients, at least in terms of prognostic ability and their chance of dying. So that's something that they apply the definition, that they know that their criteria that they came up with really do come up with differences in terms of mortality. Now, who develops ARDS? People don't just walk down the street and develop ARDS. There are certain predisposing at-risk diagnoses that people have, and as a sequela of that, they develop ARDS. And these have been classically divided into direct and indirect lung injury. Direct lung injury are things like an aspiration, lung contusion from trauma, or pneumonia and sepsis. Indirect lung injury, which from a pathogenic standpoint is actually more interesting, and people can have urosepsis, abdominal sepsis, or non-pulmonary sepsis and develop ARDS, abdominal trauma, multiple fractures, and as Jesse talked about earlier, hypertransfusion can lead to lung injury. Now this is kind of a little bit of a complicated slide that has a lot of information on it, but I'll clearly take you through it. So these numbers over here are, if you have 100 people with aspiration, somewhere around 36 to 44% of those people with aspiration will go on and develop ARDS. Or down here, if you have abdominal trauma, it's somewhere around 18%. What I did over here is looked at it in a different way. If you had 100 people with ARDS, how many of those people would have which at-risk diagnoses? And this comes from a large prospective cohort study out of Seattle that was published in the New England Journal of Medicine several years ago. And what this shows is that if you have 100 people in general with ARDS, the majority of them will either have pneumonia as the risk factor or non-pulmonary sepsis as the risk factor, accounting for about 70% of patients in general with ARDS. Trauma is much less likely, aspiration is much less likely, and this other category is really filled in a lot due to hypertransfusion, or what's called transfusion-related acute lung injury. So in general, there are all these different risk factors for ARDS, but the ones that you see the most common are pneumonia and non-pulmonary sepsis. Now, one thing we looked at when I was at Emory is not everyone there developed ARDS. Not everybody who has an aspiration pneumonia developed ARDS. It was 44%. So why was it 44%? What other effect modifiers exist that maybe change the propensity to develop ARDS in those patients who, we'll say, aspirated? And one thing we looked at was alcohol. Well, alcohol alters a lot of organ systems, causes cirrhosis of the liver, pancreatitis, cardiomyopathy, cerebellar degeneration. Except the effects of alcohol abuse in the lung were, at least until recently, relatively unexplored. My project when I was a fellow back at the University of Colorado was to look at this. We had a cohort of 351 patients, and when we simply stratified patients according to their history of alcohol abuse or no alcohol abuse, you can see that those patients who had an at-risk diagnosis, sepsis, pneumonia, that had alcohol abuse, 43% of them went on to develop ARDS, compared to only 22% of those patients who didn't have alcohol abuse. The other thing that's interesting here is that of the 102 patients in this study who developed ARDS, 52 of them had a prior history of alcohol abuse, showing that this is a common phenomenon, at least in this patient population. We then went on and did a second study, prospective cohort epidemiological study of 220 patients with septic shock, again an at-risk diagnosis for ARDS, and again found very similar findings that 70% of those patients with septic shock and alcohol abuse went on to develop ARDS, compared to only 31% of those patients who had septic shock without a history of alcohol abuse. I always get concerned when you publish things in the literature and no one else is publishing the same stuff. You kind of worry, gee, maybe I was doing something wrong or wasn't accounting for variables properly. So it was really nice that several papers have come out really confirming these findings about alcohol's effect on the susceptibility of acute lung injury. This is a paper from from Europe, from Switzerland, where they looked at patients after lung resection. Or after lung surgery. 9% of these patients had a history of alcohol abuse, which was defined as greater than 5 drinks per day. And again, you can see a very similar trend in this study. The patients who underwent lung resection with alcohol abuse, 21% developed ARDS. Lung resection, no alcohol abuse, only 2.7%. And again, of the 37 patients who developed ARDS, 16, or almost half, had a history of alcohol abuse, again showing this is a common phenomenon even in this other patient population. And finally, this is a little bit of a different study design that came out of the Mayo Clinic. It's a case-controlled study. So they looked at people that had transfusion-related acute lung injury, found a control group of patients that were basically the same, that got transfusion, that didn't develop transfusion-related acute lung injury, and went back and looked at their alcohol history. And you can see people that developed TRALI, 37% of them had a prior history of alcohol abuse. Those that didn't develop TRALI, 18%, or only 18% had a history of alcohol abuse. Again, showing that alcohol increases susceptibility to transfusion-related acute lung injury. So we kind of felt a little bit better that it's not just us finding these findings, other people from around the world in different patient populations were showing similar things. And to make a lot of work that Jesse, Dave Guido, other people at Emory University, now here, and people at the University of Colorado looked at, we published a review article on this alcoholic lung in the Lancet, showing here's a normal alveoli on this side, this is an alcoholic alveolus on this side, showing all the basal abnormalities that alcohol does to the alveolus that increases susceptibility to acute lung injury, increased number of apoptotic type 2 cells, decreased antioxidant capacity, increased utilization of that antioxidant capacity, changes in surfactant synthesis and secretion, sodium channel activity, etc. So it's sort of, there's a lot of basal things that are going on that once this lung is exposed to stress, it's more likely to break down and develop acute lung injury. The other thing from the epidemiology that's happened is that there's been improved mortality in patients with ARDS. Over here is a study that was published in JAMA by John Milberg that shows from 1983 to 1998 a decrease in the mortality rates or case fatality rates in patients with ARDS. This is a more recent study published by Sarah Erickson, who was at Emory at the time, that shows continuation of that improvement in mortality. So the mortality in patients with ARDS who had pneumonia as a risk factor in 1996 was 36%, and by the year 2004 to 2005 was down to 28%. And you can see this in almost all the categories except the trauma patients, where the mortality had been so low that really it was hard to see a difference and the numbers are small. And if you look at all these patients together, from 1996 the mortality rate was 35% from ARDS, and in 2004-2005 it dropped to 26%. So we're clearly doing something better to improve the outcome of these patients, and we'll come back to what those etiologies might be. So to come back to the case presentation, and we're going to work through this 54-year-old gentleman throughout the remainder of the talk. His echocardiogram was normal, so it's unlikely this is cardiogenic pulmonary edema. Cultures were obtained, he was started on antibiotics, but over the night his clinical course deteriorated, increasing oxygenation requirements, increasing tachypnea, eventually patients intubated and placed on mechanical ventilation. And the question is, what do you do with the ventilator? What are the right strategies to do on mechanical ventilation for this patient who now clearly does meet the criteria for ARDS? So I think you have to take a step back and say, well, what should a ventilator do in anybody? Why do we put people on mechanical ventilation? And it's really a balancing act. The benefits of putting someone on mechanical ventilation are you can improve their oxygenation, you can improve their ventilation and blow off their CO2, and I think most importantly, you can decrease their work of breathing, which can be very considerable in people in respiratory failure. But there are disadvantages in mechanical ventilation. We weren't made to have air blown into our lungs, and when that happens, it can cause patient discomfort, or more importantly, it can cause ventilator-induced lung injury. And coming up with the right mode of ventilation is a balancing act between the good and the bad effects of mechanical ventilation. When we talk about the bad effects and we talk about ventilator-induced lung injury, most of the times we think of what I call macroscopic barrier trauma, where someone would develop a pneumothorax or sub-Q emphysema. You can see here there have also been cases of subcutaneous emphysema, pneumomediastinum, and occasionally systemic air embolism. But on a microscopic level, by pushing positive pressure into someone's lung, you can develop diffuse alveolar damage, which is actually the same pathological pattern you would see in someone with ARDS. So to go back a little bit, there were studies that were performed in the 1970s where they took normal animals. These were done in rats. They've been done in every other animal that exists on the planet with similar results. And they put the put the animal on a ventilator and used higher and higher pressures at 14, 30, and 45 centimeters of water pressure. And as the pressures increased, there was more and more damage to the lungs. I just want to reiterate, these were normal animals at the beginning. These weren't animals that were septic or aspirate. These were completely normal animals. And in this higher group, the 45 centimeters of water, there was alveolar and perivascular edema, severe hypoxemia, decreased compliance. And the majority of these animals ventilated at 45 centimeters of water pressure didn't even make it through the entire hour of the study. Most of them died after 20 minutes. If you look at their lungs just grossly, these were the lungs. What's going on? Okay, I'm not sure what's going on with the slide, but So over here on the left, it's a pretty normal lung. And you can see here on the right, it looks like a liver. So this is a lung that was ventilated with 45 centimeters of water pressure. And there's just such damage to the lung that there's just all this edema that's formed. Again, an otherwise healthy animal. No idea what's going on here. Okay, maybe I fixed it. I hope I fixed it. So, and what they did here is when they added some positive end expiratory pressure at 10 centimeters of water to the high pressure group, that was somewhat protective to this damage that caused to the lung. And these investigators back in 1974 felt that these high inflating pressures might have caused damage to the lung due to surfactant depletion. Now, these are electron microscopy pictures of the lung, and after 5 to 10 minutes, you can see here that here is an epithelial cell, here's an endothelial cell, and after just being on a ventilator for 5 minutes, there was an increase in extravascular lung water, increased albumin leak, suggestive of permeability defects. And here you can see that this is an endothelial cell being torn away from the basement membrane here, just due to this ventilator-induced lung injury. After 20 minutes, there was an outpouring of high protein content pulmonary edema, epithelial cell injury, hyaline membranes, which are really just dead cells. And you really can't even tell that this is an alveolus. Here's sort of an endothelial cell. Here's some blood cells in the alveolar space. Here are the hyaline membranes. And again, normal animals, 20 minutes, the lungs are destroyed by being ventilated with high pressures. So people start to do these pressure volume curves in animals and patients with ARDS, and we'll go through this very quickly. So what happens when the lung inflates down here, as you're increasing the pressure in the lung, you don't get a lot of change in volume initially. But then right here, the lung opens up. And at that point, when the lung opens up, small changes in pressure fill the lung. And then you get up here, and the lung's already inflated. You're trying to push more and more air into already open alveoli, and you start getting minor changes in volume and greater changes in pressure. And people have started to think that maybe the way we should ventilate people is between these two inflection points. So you would want to keep the lung open so that it's not closing and being torn open again, but you also don't want to overdistend the alveoli with the air you're pushing in to cause ventilator-induced lung injury. And this is called the lower inflection point, and this is called the upper inflection point. So the concept is if you use too high tidal volumes, you'll lead to overdistension and what's called volume trauma. If you let the lung fully collapse and have to rip it open each time with the ventilator, that is called atelect trauma, and this cyclic recruitment, de-recruitment injury will occur, and maybe that can be avoided with positive end expiratory pressure, as we'll talk about. And this whole process has led to the concept that the lung can be an inflammatory organ. If there's damage being caused to the lung, will release inflammatory cytokines, go to other parts of the lung or other parts of the body, and cause multi-organ system failure. So the question is, does this lung protective strategy, this concept of ventilating between the upper and lower inflection point with lower tidal volumes, does it work clinically? And the answer is yes. So there was a large multi-center clinical trial done by the ARDS network of patients with the old definition of acute lung injury, or ARDS. And if you look at the outcome of this study of over 800 people, they used low tidal volume ventilation of 6 cc's per kilogram, which was estimated to be between the lower and upper inflection point. They avoided alveolar overdistension. They ventilated below that upper inflection point. And you can see that simply by changing the tidal volume on the ventilator in patients with ARDS from a high tidal volume of 12 cc's per kilogram to this lower tidal volume ventilation, you improve mortality from close to 40% to 31%. People were more likely to get off the ventilator and get off the ventilator sooner. This is a major breakthrough in the treatment of patients with ARDS that showed by simply lowering the tidal volumes, you can improve mortality. And this should be, I think, the standard of care for any patient that has ARDS in any of your intensive care units. So, it's weird. Okay. So the other side of this is this atelect trauma. So how do you prevent the lungs from fully deflating, having air pushed in, being ripped open, and causing damage that way? And the way you can do that is with something called positive end expiratory pressure, which is a low degree of positive pressure that's kept in the entire ventilatory circuit the entire time. The good parts of PEEP are you can improve oxygenation. The bad parts is this positive pressure that's kept in the cycle the whole time can lead to hypotension, can lead to barotrauma, and in neurosurgical patients has been shown to increase the intracranial pressure. And this is a CAT scan of a patient with ARDS that shows what happens to these alveolar infiltrates as you increase the amount of PEEP in the circuit. This is with no PEEP. You can see here at 5 centimeters of water PEEP, some of these infiltrates go away. And at higher levels of PEEP, they go away, and even higher levels of PEEP, they go away completely. So you can see radiographically, there might be some benefits of using higher levels of PEEP in these patients. So how much PEEP should be used? And there have been 3 large studies, randomized clinical trials published in high-impact journals, so all of them have been in JAMA. And if you combine it, they've studied over 2,000 patients. All these studies use the typical low tidal volume ventilation and weaning protocols. And to give you an idea of the differences between the PEEP, if somebody was on 60% at VO2, in the low PEEP strategy, they might be on a PEEP of 10. In the high PEEP strategy, they'd be on a PEEP of 20. So twice as much of this positive end expiratory pressure. They give you the difference between the low and the high PEEP protocols. Okay, so Maureen Mead from Canada did a meta-analysis of these three studies, and what she showed was actually very important. Number one, as I said, over 2,000 patients from 3 clinical trials. There was a treatment effect that varied with the severity of ARDS. So in those patients, and I converted this to the Berlin definition, okay, in those patients with moderate to severe ARDS, the mortality with the higher PEEP group was 34%, and the lower PEEP group was 39%. So this shows with an odds ratio of 0.45 and a risk ratio of 0.9, that in people with moderate to severe ARDS, using a high PEEP protocol is beneficial for mortality. In people with mild ARDS, there was a trend, but not a difference in mortality in the other way, that the lower PEEP group seemed to do better. And the rates of pneumothorax and vasopressor use were the same. So I think the way most people interpret this study is always use low tidal volume ventilation, but in patients with severe ARDS that are severely hypoxemic that meet the moderate to severe Berlin definition, it is very reasonable and advantageous potentially to use a higher PEEP protocol. So again, to go back to this figure, the way we should ventilate patients with ARDS is with low tidal volume ventilation, 6 cc's per kilogram. It prevents overdistension. You ventilate below this upper inflection point, use higher levels of PEEP, prevent analytic trauma, and ventilate above the lower inflection point, so that this is, as the air is going in and out of the lung, it's going between these 2 points. Go back to the case, patients being ventilated with the ARDS network low tidal volume protocol, high PEEP protocol, but they're still hypoxic and they're fighting the ventilator. What else can you do to improve their pulmonary function? So you've done all the routine steps, the patient's still not doing them. So there was a recent study that came out in the New England Journal that talked about using neuromuscular blockade or paralytic agents for patients with severe ARDS. The reasoning behind this is that it would reduce ventilator-induced lung injury by decreasing the metabolic demands of the patient and improving their interface so that they wouldn't fight the ventilator as much and cause ventilator-induced lung injury. And it's because neuromuscular blockade can reduce the work of breathing, reduce the actual tidal volume that's delivered, and reduce pulmonary blood flow, which may decrease the accumulation of alveolar fluid. They enrolled 340 ARDS patients with moderate to severe ARDS. All these patients were deeply sedated, and the treatment arm received neuromuscular blockade for only the first 48 hours, and it wasn't titrated to effect. It was a set dose. You can see here in the study, in the paralytic arm, or the neuromuscular blockade arm, there is an improvement in outcome compared to the placebo arm. That started to occur at about day 12, even though the patients only received the neuromuscular blockade for 48 hours. So I think this is a very intriguing article. I think it's unclear what the long-term effects of using neuromuscular blockade are on neuromuscular function. It's kind of strange that the Kaplan-Meier curves start to separate at 12 and then actually separate at 18 days. The crude mortality was really not different between the two groups. They used an adjusted mortality. So I think the way most people would kind of conclude for this study is that I think people feel a little bit more comfortable using parallel agents for patients who aren't oxygenating well for this short 48 hours. But most investigators in the editorial that accompanied this article in the New England Journal of Medicine and other editorials down the road have really said that there should be a second validated study before this becomes standard of care. The other thing you can do, again, patients not oxygenating well, what other things can you do to help them oxygenate? So this is a CAT scan of a patient with ARDS. You can see that most of their infiltrates are in the supine position here. The lungs in the anterior part actually look okay. And in general, when someone's lying on their back, the amount of perfusion that's going to this part of the lungs is going to be greater. Therefore, more blood's going to the part of the lungs which have the worst infiltrates. If you simply flip the patient upside down, those infiltrates actually don't move that much. So those infiltrates now become sort of anterior, but all the blood goes now to the posterior part of the lung, which is now looking pretty good. So you can see just conceptually here that if you turn someone over, you're going to have more blood flow going to the healthy part of the lung and less blood flow going to the unhealthy part of the lung. And it would sort of make sense that that might help with oxygenation. And that's called prone positioning ventilation. Literally all you do, it's not this easy, but you flip the person over and have them lie on their stomach instead of lying on their back. There have been several multiple clinical trials, and all have basically the same results. And here's a picture of a patient in a prone position ventilation lying on their stomach instead of lying on their back. We'll just go over the most recent of these prone position studies. It was a study of 342 patients with moderate to severe ARDS, and it showed the same thing that all these studies show. Prone positioning improves oxygenation. It also increases the number of complications such as vomiting, desaturation, airway obstruction, need for increased sedation. Sometimes the endotracheal tube comes out, but that's very rare. But it really doesn't improve outcome. So again, when you use prone positioning ventilation, if you really just can't oxygenate somebody, they don't have a lot of tubes in place. It's not like they have 6 chest tubes, which may become dislodged. It's very reasonable to flip the person over to just try to buy yourself some time to get them to oxygenate better. But in general, most people feel that prone positioning does not improve outcome, but does improve oxygenation. Okay. The patient, you decide to start them on a neuromuscular blocker. They stabilize. They're hemodynamically stable for 12 hours. You've stopped the neuromuscular blocker. We've talked a lot recently about ventilators. What other things should you do for these patients with ARDS? So what other medical interventions should the patient be receiving to improve their outcome? Well, the most important thing we've probably done over the last 20 years that accounts for the improved mortality is, number one, low tide of ion ventilation has probably been the biggest breakthrough. But just kind of good supportive care, being a good ICU doctor is really just being compulsive and making sure that you're dotting all your I's and crossing your T's, which means DVT prophylaxis, stress ulcer prophylaxis, limiting blood transfusions, having a transfusion trigger of less than 7, limiting the amount of sedation the patient receives. Peter Prograno's study shows that taking out central lines that are no longer necessary decreases the risk of catheter infections, and different ventilator-associated pneumonia prophylaxis. The other thing that you should consider doing is a conservative fluid strategy. So the ARDS Network, about 7 years ago, published a study that looked at how you should deal with fluid strategies in patients with ARDS. Should you give them fluid to help perfuse their kidneys, or should you dry them out to help get the fluid out of their lungs? In a fluid conservative strategy, what was done is patients received Lasix. This would favor a dry lung and maybe hurt the kidney by decreasing perfusion. Try to get their CVP to 4 if they had a pulmonary catheter in, a occlusion or wedge pressure of less than 8. The other side of the coin was a liberal fluid strategy where you're giving fluids, pushing the CVP to the 10 to 14 range, or the wedge pressure to 14 to 18. This might favor the kidneys, but might hurt the lungs by having extra fluid being in the lung. So this was a classic argument that existed for years about what to do with fluid management in people with ARDS that have leaky capillaries. Okay, on that slide, it's supposed to, this one I can do by memory. So what this slide shows is a diagram of ventilator-free days. And it shows that using a fluid conservative strategy, so drying the patient out when they're hemodynamically stable, approaching a CVP of 4, using furosemide or another diuretic. We use furosemide drips. It's just an easier way of doing it. And if you do that for patients with ARDS, you get them off the ventilator 2.5 days sooner. So that's a good thing. I mean, if you can get someone off the ventilator in 2.5 days simply by giving them a diuretic, it's probably worthwhile doing. There was no change in mortality based on it, but I would say that getting someone off the ventilator sooner is a positive outcome. And again, something you should consider doing in your patients with ARDS who are hemodynamically stable for more than 12 hours. The other thing that the ARDS network has studied is feeding. So when she starts feeding someone with ARDS, and is that important? We recently completed what was called the Eden trial. This was to try to figure out, should we feed someone early? And there had been improved outcomes in observational studies of patients with ARDS that showed that fewer infections, shorter duration of mechanical ventilation, improved mortality by feeding somebody early and getting them to their goal feeding rate. But it's also been shown that what was called hypocaloric or trophic feedings, where you just trickle in a little bit of feedings into the lung, not worrying so much about their caloric content, but just getting their guts to move, was beneficial. So there was this equipoise, or there's uncertainty in how to feed people with ARDS. And as you can see, this is a patient with ARDS, and here's their feeding tube going into their nose that they're being fed through. The results of the Eden study were essentially negative. It was a very well done study. You can see there's great separation between the groups, at the time of enrollment up to 7 days. This was the full feeding group that was receiving over 1,300 calories per day. The trophic feeding group, less than 400. If you look at their caloric goal, the difference was between about 25% up to 80%. And this is the best target that's ever been achieved in a large clinical trial of achieving caloric goals in patients who are critically ill. You can see down here, there was no difference in outcome, mortality, between the early versus late feeding group. There were some complications. The full feeding group were more likely to have vomiting, increased residual volume, constipation, and higher glucose levels over the first 6 days. So it's a negative trial, and what do you do with results like that? I think you can make a case that not feeding someone's reasonable because you're going to avoid these complications. But I think you can also feel comfortable that if you don't remember to feed somebody over the first few days of their ARDS, you're not going to cause them any harm that way. Just trying to get the different things to show up. So, okay. So to get back to the case presentation, patient improves over the next 10 to 14 days. They're extubated and they move out of the intensive care unit to the floor of the hospital. The question is, what should you do for that patient after they leave the intensive care unit? Whether you're a critical care doctor or you're a general internist who's going to see someone like this in your office. And this has received a lot of awareness, a lot of press recently, to the extent that it was published. There was an article in the Wall Street Journal 2 years ago that really talked about looking at life after people leave the intensive care unit. What can we do to improve their quality of life? So the person who's done most of the work in this area of looking at quality of life in ARDS survivors is Margaret Herridge from the University of Toronto. And she's taught a cohort of patients with ARDS. And she first showed in the New England Journal of Medicine, well, I think 10 years ago now, that 43% of ARDS survivors had significant limitation in their general physical function. You would think that they would complain of breathing problems, that they would be short of breath, and they are to some extent, but their largest decrements were in physical function. They were unable to lift and carry their groceries, climb stairs, and walk moderate distance. And if you look at this table from Margaret's work, or paper, the number of people that returned to work at 12 months was only 49%. So these people are so debilitated, they're not able to go back to their job. Margaret also followed these people and showed that their limitations persisted for up to 5 years. So this isn't even something that's transient, that only occurs for a few months. These people are severely debilitated for up to 5 years after they develop their ARDS. Their pulmonary function testing, median-wise, are normal, but that means that there are 25% that have abnormal pulmonary function testing, and their physical function remained abnormal and 1 standard deviation below the normal scores for their age, sex, max control, and only 77% had returned to work by 5 years. So that's still about 25%, of 1 out of 4 people that were working before their ARDS don't go back to work afterwards. This up here should say post-traumatic stress disorder in ARDS survivors. This is a study published in Critical Care Medicine by a German group that shows that if you look at the degree of post-traumatic stress in patients with ARDS, it was higher than a general surgical control group and higher than UN soldiers, control group number 3, that were working in Cambodia at the time of Pol Pot. So these people that are in the intensive care unit have worse PTSD than people that were seeing genocide occur in countries. So this is, again, a major problem to worry about in your patients that survive, psychological and psychiatric problems in the ARDS survivors. And again, it makes sense. They just went through a life-threatening illness. That of course they're going to have concerns and problems with post-traumatic stress disorder from that. Mark Mickelson used data from the ARDS FACT trial, the fluid trial, that showed that a fluid conservative strategy is beneficial, and tested ARDS survivors at 2, and this should say 12 months after hospital discharge, and showed that a significant portion of these patients have higher cognitive function problems. Now, they might have had it beforehand, and I can't tell you its cause and effect, but if you're taking care of these people afterwards, it's important to know that 49% are going to have problems with executive function, 55% are going to have cognitive impairment, 16% are going to have verbal fluency issues and some memory issues. So again, realize when you're seeing someone after they developed ARDS in your outpatient clinic, you're going to have some neuropsychological problems that you're going to have to deal with. This, I think up here says depression and anxiety in ARDS survivors. This is a study that Dale Needham performed, published in the major pulmonary journal recently, 186 ARDS survivors, and showed that their hospital anxiety depression scale to diagnose depression, and the cumulative incidence of depression or depression symptoms was 40%. And the risk factors that were associated with increased symptoms of depression were baseline disability, unemployment, medical comorbidity, and a low blood glucose while they were in the hospital. So again, taking care of someone with ARDS, lucky enough to survive the hospital, they go home. Up to 2 years, 40%, or 4 out of 10 of those people are going to suffer symptoms of depression. And I think as providers for them, we need to be aware of that and make sure they get the right care for that. And again, let's see if I can get this to work. I'm just messing it up more. Okay. The other thing is this is a study that was that we just completed that's going to be published soon. We've talked about a lot of the long-term outcomes being psychological, neuromuscular weakness. What this slide shows is we combined high-resolution CT scan findings for patients 180 days or 6 months after they developed ARDS, and showed that lung dysfunction really does correlate with quality of life. So there's been the spectrum's kind of swung to being that we worry more about neuromuscular disease, psychological dysfunction, depression, but these people actually still do suffer from pulmonary dysfunction even in the setting of low tidal volume ventilation. Okay. So this was the conclusion slide. So kind of take-home messages here, what to worry about, or what to know that's new about ARDS. Again, new definition. So when you're on rounds and you're saying if someone has ARDS or not, make sure you use the Berlin definition to define your patients. Ventilatory strategies, always use low tidal volume ventilation. In patients with moderate to severe ARDS, use a high PEEP strategy. If they're not doing well on that, You can use neuromuscular blockade, prone positioning. Didn't have time, but I'd be happy to answer questions about using extracorporeal membrane oxygenation. Other things you should do for the patients, not too concerned about when you should feed them, but you should always use the fluid conservative strategy, especially when patients have been hemodynamically stable for 12 hours. And there's a really, as these people are doing better and surviving the ICU, their effects on long-term outcome are really severe in terms of weakness, depression, PTSD, and also their respiratory status takes a while to get better. So hopefully I've been able to update you on, number one, how to diagnose patients with ARDS and other things to think about once they have ARDS, how to treat them, and what to think about after they leave the hospital. Again, thank you very much for the invitation. Sorry about the problems here, but I think we kind of worked through those a little bit, and I'd be happy to answer any questions if we have the time.
So Mark, I don't want you to develop PTSD from the slide effect, because the message was very clear. This was outstanding, and knowing you, I'm not surprised. I'm glad that you actually spent a lot of the lecture on post-ARDS, because training in the 1980s, I remember that you were told, and you learned from books, that if you survive ARDS, you were fine. And we know that that's not the case, a lot because of the work that you have pioneered and others. And you also mentioned in the initial part of the conference how distension or over-distension alveoli can induce some biological damage. Can what's the thinking about the biological things that are happening in that lung that could affect other organs, that could ultimately perpetuate organ dysfunction later on? I'm making that up, but tell me about that.
So it's a good question. I mean, it's an interesting concept that if you think about what fuels inflammation, I don't think people before this ventilator-induced lung injury would have thought the lung could do that. But it's been very clearly shown if you ventilate the lung in the wrong way, and I can go into more depth of this, you cause the release of inflammatory cytokines from the lung to other organs. And it's been clearly shown that improper ventilation is likely associated with the development of acute renal failure down the road. So you have someone with ARDS, why do they develop ATN and acute renal failure? It might be related to the way that they're being ventilated, causing this inflammatory cytokine storm. In terms of neuromuscular dysfunction, no one's really specifically tied the ventilatory strategy, but the things that cause the critical illness polyneuromyopathy. So the same things that are happening in the lung that cause someone to have a low blood pressure to cause renal failure, those same pathological changes are occurring in their muscles and nerves. So it's very feasible to think that improper mechanical ventilation could, though it's never been shown, lead to more likely to occur, to develop weakness in terms of the myopathies and the neuropathies that you see.
Questions? Yes, sir, Rodrigo.
Yeah, I have two questions. The first one is, despite the knowledge that all type of hole does not seem to better out, it appears that in clinical practice, this is not something that people apply with. A lot of alternatives seem to ventilated with way more consistency. So the first question is, what can be done to applies low type of hole? The second question is, do you feel that low type of hole should be applied to all patients in medicine?
Yeah, those are great questions. So the first one, I mean, there's really becoming an increased science of dissemination and implementation research. And I think it's really, what we've done is change the culture in the intensive care unit in a multidisciplinary approach, and really have everybody from the nurses, most importantly the respiratory therapists, buy into it. So that if someone has ARDS, we have it that as a physician, you have to opt out of that. So the standard of care that will be done if you do nothing as a physician for ARDS is to look at low tidal volume ventilation. And so there are steps like that that make it so that it's hard to say you're not going to do that, and you sort of have to justify that. In terms of the second thing, should everyone be on low tidal volume ventilation? I think that's a hard question to answer. And part of, in other talks I give, how do we start off at the 10 cc's per kilogram that the older of us were taught, that comes from the anesthesia literature and was then extrapolated to everybody. So I'm not sure that's right. And I think in general, it's fine to use low tidal volume ventilation in most people. As you would know, people that have obstructive lung disease maybe would be more likely to have problems with low tidal volume ventilation. So we have it as, again, an opt-out for everybody that's put on a ventilator, but there are clearly other patient populations where it's probably not the right thing to do.
Dr. Nunley.
Mark, thank you for that excellent update. First of all, also 2 questions. One, when you have a patient with ARDS, do you always look at the flow pressure volume curve on your graphics to set your PEEP above the lower inflection point? And the second question is, where are we today on the roller coaster of steroids and ARDS? Yes, no, early, late, how much?
Yeah. So in terms of the first one, I mean, we used to do that, David, and I think it's an okay to do it. Just remember Marcelo Amato's papers that did that. It was a static pressure volume curve, which is maybe slightly different than when you get on the ventilator. What we normally do, again, to get back to the previous question to make it user-friendly, is we have protocols so that if someone falls into that moderate, severe ARDS group, they automatically get put on the high PEEP protocol. So it sort of take it out of your hands, seems to work pretty well, and it's more likely to get implemented. In terms of steroids, it's very controversial. It's very difficult. I mean, I think I've been brainwashed being part of the ARDS network that I don't think it's a beneficial thing to do, and it's not something I normally do. It's actually why I started the talk with, you got to worry about these other diseases. Obviously, if the person gets biopsied and they have cryptogenic organizing pneumonia, they need steroids, okay? So where I worry about it is where I don't have a clear-cut at-risk diagnosis. Somebody walks in with diffuse infiltrates, they're really not febrile, they don't have a white count, maybe they had the flu 3 months ago or 3 weeks ago. In those situations, I worry more about that the diagnosis of ARDS is wrong, they actually have an interstitial lung disease. And in that situation, I might be more aggressive to biopsy the person because I think they might need steroids. But in general, I don't routinely give steroids. I'm more on the, I don't think it's been shown to be beneficial.
Having said that, we know that there is one place in the United States where steroids work, Memphis. Lori.
Thank you. Wonderful talk. I had a question about the long-term outcomes you mentioned. I appreciate you bringing attention to that problem. Are there any interventions that you tried at your institution or that you tried that have been successful in decreasing the quality of life burdens of these survivors?
Yeah, no, people are really working hard on that. People are looking at cognitive function and physical function. As you know, J.P. Kress published a paper in the Lancet for all ICU comers. There wasn't a very clear control group for physical therapy, and people are getting very interested in using physical therapy. And as Jesse alluded to, one of the grants we have is a very well-controlled 1-month study of physical therapy to try to improve physical function. But again, as I raised, there are neuropsychological issues, there are cognitive issues. People are starting to do little stuff, I'm not sure this is going to work, where you have people play video games while they're in the ICU. It just seems kind of like we try to tell our kids not to do that, and now we're telling the patients to do it. It doesn't quite feel right, but people are working on things like that.
One last question.
As a cardiologist, statins have been a revolution. And when you think about the history of female injury there, could you please comment on statins?
Sure, there was one small study published out of Ireland. I think it was 60 people. It was a randomized controlled trial of statins for ARDS that had some intriguing biological outcomes. The study that the ARDS network's doing now, funded by the NHLBI, is a 1,000-patient study of patients with ARDS that are randomized to a statin versus control. 604 people have been enrolled into the study as of yesterday, so hopefully we'll have an answer to that soon.
In 1996, I met Dr. Marc Moss as a junior assistant professor starting to figure out what he's going to do for the next few years in his career. And today, I can't tell you how proud I am that we have one of the leaders of pulmonary academic medicine and that I can call my friend. Thank you so much.
Thanks, Jesse.
know what history was this one.
You did